The title of the lecture is A Catastrophic Failure in Radiotherapy, the Therac 25 Experience. So we've been here for the week to learn about linear accelerators, and one of the machines that is really worth noting is the Therac 25. It really was a very interesting machine technologically. It really was a technological wonder. This machine was designed in Canada at Chalk River in the early 1980s by the Accelerator Physics group there. It was based on a theoretical Russian paper that was published sometime before that, and the idea was that a single waveguide could achieve up to twice the maximum energy of that waveguide, and you could also do a very clever trick with that, and you could actually vary that energy in a completely variable way from anywhere from 0 to twice the accelerating waveguide's maximum potential energy. So this machine was developed in Chalk River. It was commercialized by Atomic Energy of Canada Limited, Commercial Products Division, and it was commercialized and sold throughout the world and in Canada. So this is a little diagram explaining how this machine works. This is an excerpt from a very rather well-known text by Karsmark. So this is a diagram over here of the waveguide. So you have over here, you have an accelerating waveguide, and we have an electron going over here injecting electrons. However, what's very different about this waveguide, what people who learned about this week, is that the bending chamber is over here on the same side as where the gun is, as opposed to normally where you'd expect it to be over here. So the electron beam somehow has to go down here, and what these designers did, and what this Russian paper said was, what you could do is you could actually send this electron beam down the waveguide, turn it around, send it back in the same waveguide, and then goes to the bending chamber at the gun end of the machine, as opposed to the distal end. So this is a very interesting idea, and so this is what they built. It has very interesting features. So it had this turnaround magnet, which is very novel and very difficult to do. The way it worked is they utilize the fact that in a standing waveguide, we do have electric fields that go in both the forward direction and the reverse direction. So the idea was that you could use while the forward direction electric field was accelerating the electrons towards the turnaround magnet, at the same time the reverse direction electric field could be accelerating electrons backwards towards the gun and then towards the bending chamber, which could be used to make into a useful therapy beam. So just again going back to some of the diagrams that we had earlier in the course, what you have over here is at the different cycles through the RF cycle, you have an electron over here accelerating down the positive end of the waveguide. You also could have another electron entering the far end of the waveguide, being accelerated through by the reverse field at the same time. And so this paper had said that theoretically this should be possible, and when the people of the Accelerator Physics branch in Chalk River, when they built it, they actually showed that it was true. That you could actually do this, and you can accelerate in both directions, and thereby you could have twice the energy of the machine, and so improving the shunt, effectively improving the shunt efficiency, or the shunt impedance of this waveguide. What you could also do is you could also time the electrons as they were coming back into the waveguide, and you could adjust the phase of the electron with the RF phase, and that's how you could actually get anywhere from twice the energy down to 0 if you actually had destructive or deceleration of the electron beam. So this is what you show over here. So the way this worked with the electron gun over here, the electrons are accelerated down the waveguide, they turn around, and then the waveguide, the turnaround magnet could be placed at the right position so that the electrons could then be sent back towards the gun again, and then through a bending chamber, and then they could have up to twice the energy of the waveguide. They used some very interesting RF cavity design. So this had a very innovative way of doing coupling. So it uses these magnetic coupling slots, which are shown over here, and it also had a very it used a very thin magnetic cavity, which we discussed earlier, in order to make sure that the shunt impedance was as high as possible. So in terms of accelerator physics, it was a very interesting machine. However, it was even more interesting than that. They even did more technologically. This was also the first linear accelerator that was also computer controlled. So that it was completely controlled by a computer interface. So remember, this is the 1980s, so this was quite some time ago. The computer was a DEC VT100 terminal, and what this allowed was manual entry of patient treatment information directly into the console. And this is what the console looked like. So you can enter data into here. You can enter information about how the machine was set up. You can enter monitor unit information, and then the machine will then accept that information, and then program it into the whole accelerator, and then deliver the radiation. So in theory, this was a good idea. But it turns out that there are some failure modes of these machines that can actually be rather dangerous if you're not looking out for them. And the modes what happened with this machine, as we learned this week, there are two modes of operation. There's a photon mode where you have an electron beam striking a target. The target then goes through an upper collimator, flattening filter, jaws, and so on, and makes a therapeutic beam. You can also have a mode where you have an electron beam, and here the target is removed. You still go through the upper collimator, then you use scattering foils, the dose chamber, and a collimation system. And as we learned when we talked about the powers, the amount of X-ray current that you need in order to generate a photon beam is much higher than you need in electron mode. And so the whole safety of the system depends on this target being in place in order to make sure that high power is being absorbed by the target and not too much of it is going into the electron beam. So what I'm going to do now is I'm going to turn over the story to Dr. Brian Wilson. Dr. Brian Wilson is a senior scientist here at the Ontario Cancer Institute in Toronto. However, in a former life, he was also the head of medical physics at the Hamilton Regional Cancer Center during the time when that institution had a Therac 25. And we're lucky to have him here to talk to us about his personal experiences with this device and in responding to an accident that I'm sure I'm glad that I wasn't there when that happened. So I'm going to now pass it over to Dr. Wilson.
So I just run from here.
You can run it from there.
Okay, thanks. How do I get the slides? Oh, I have to look up.
And I will bring the slides back.
You'll bring the slides.
Okay. Well, thank you very much.
So it's good to be here. This is the second time I've sort of given this this talk. We did it last year. And I guess I'm here not because I have any expertise in accelerators, either from the engineering point of view or the physics point of view, nor do I have any particular expertise in safety. I'm here really because I was one of the players in this sequence of events, as you will see in there. It was just to give you a sense of what this is like from a personal point of view. So let me just start by introducing. If you Google Therac 25, you get lots of very useful scientific information. You also find out there's actually a play entitled, well, a short play, as you see, entitled Therac 25, which I bought thinking it would be based around the story that you're about to hear, but in fact it's kind of a love story that happened to take place in Princess Margaret Hospital. But nevertheless is of historic interest. So the story is as follows, that between 85 and 87, there were a series of design flaws identified in the Therac 25, which resulted in significant overdoses of radiation on at least 6 different occasions, resulting in 5 deaths. And that the end result of that was that ultimately, a few years later, the machine design was found to be defective by FDA and was recalled by the company. So there's quite a good set of reference materials on this. For instance, the article by Nancy Levison is also available on the web and has a lot of detailed information if you're interested in having a look at that. And there are other sources of information. But it's important to point out that even in the most thorough analysis, which was by Nancy Levinson, which was done within a decade of the events, or within 5 or 6 years, it was still found to be very difficult to reconstruct the actual events. And so all of this is sort of people's memories, some documentation cobbled together as best we can. So I'll first of all go through the sequence of the accidents, at least as they are documented. So the story starts with in June 1985 in Georgia, in Marietta, Georgia, where a patient, a post-lumpectomy patient, was receiving 10 MV electron therapy, and following the treatment made a claim or a statement that she felt that she'd been burned. The physicist there contacted the ACL, and the ACL's response was, that's impossible. There is no way that improper scanning of the electron beam could happen. This was an electron treatment, and therefore, first possibility was that the scanning had failed. A lawsuit was filed by the patient. It was settled out of court. Subsequently, it was estimated there was about 150 to 200 gray doors, which you recognize as significantly higher than intended. But it was not possible to really reconstruct this event because since at that time the computer running these machines was PEP11, which, if you know computer history, is about a tenth or maybe it's a hundredth the size of my BlackBerry in terms of memory, and therefore there was no paper trail of this or electronic trail. And there was some issues around the reporting of this. It wasn't reported to the FDA until after later accidents, and at that time it turned out there was not a requirement of the FDA that incidents causing harm or potential harm be reported by the institution. It was only a requirement they be reported by the manufacturer or supplier, and so it was not reported. So other Therac users, Therac 25 users, were not made aware that this had happened. So this was the event that I was involved in, and I'll tell you a little later about my personal memories of this. So in Hamilton, we had a cervix cancer patient receiving X-ray therapy. The machine came up with error messages when the operator tried to make it run with a treatment pause, which was considered a non-serious fault. It happened many times with this machine that you had to restart it. That was a common observation by the operators. So the operator repeated it 4 times. There was nothing wrong, but the patient complained of, as you burning and tingling, like an electric shock sensation in her hip. And then 3 days later came with significant symptoms. Machine was taken out of service. AECL were informed. The FDA, the Canadian Radiation Protection Bureau, and other users were informed, although in retrospect, it may have been that they were not told the patient's injury had occurred. And users were told to confirm visually that the turntable was in the correct position. Until further notice, there were lawsuits, including one naming me, for reasons that were obscure to me at least. But it was a generic lawsuit with suits and countersuits. It was all settled out of court. Patient died of cancer, but autopsy indicated that there was massive damage that would have required a hip replacement, and retrospectively she received about 150 grand. Then in December '85 in Washington at Yakima, after some modifications that were made based on the incident in Hamilton, again, a pelvic fracture needed treatment. The patient ended up with stripes of reddening on the skin. There were investigations such as could this have been caused by abnormal sensitivity that was exacerbated by the fact that the patient had an electric blanket. But when you measured the width of the wires in the electric blanket, they were different from the widths of the stripes, and that wasn't an explanation. So lots of explanations were looked for to try and explain this away. But it was considered that after ACL analyzed this, that it could not have been produced by malfunction or operator error. And there were 2 pages of technical reasons given why this machine could not possibly overdose. There was no further investigation. It was put down to unknown cause. The patient had significant symptoms, but survived. The modifications that were made by ACL at that time were analyzed by the ACL engineers and were considered to have improved the safety by at least 5 orders of magnitude. You know, for discussion later, what does that mean? That one can calculate that this is 100,000 times safer. You see the problem. And then 1 year later at Yakima, there's a second accident. We'll come to that. In Tyler, Texas, moving down to the U.S., is a high-energy electron treatment near the spine. The operator was very experienced in using the Therac, and that's important, as it turned out. That the operator was really experienced in entering the prescription. Again, a malfunction, treatment pause, error malfunction 45 came up. Unfortunately, the user manual told you nothing about what that meant. And therefore, it was not possible to interpret what had happened. The display indicated only 6 monitors units delivered, 200 had been prescribed, and therefore the operator considered that the treatment had not been given. It turns out that, and so this happened twice. The operator restarted, reset twice. Unfortunately, the video was unplugged and the audio was broken in communication with the patient in the room. The patient eventually leapt up from the table, ran to the door, and pounded on the door to get out. Physicists kept the machine in service after checking the calibration. Atomic Energy could not reproduce the fault, and were told, the people locally were told the ACL knew of no other incident. Remember, this is after the previous events. Since the patient reported it felt like a shock, they did an electrical analysis, and it was the possibility of electric shock was ruled out. The machine was put back into service, and subsequently it was determined that the data entry speed was a key factor. So this operator being very experienced meant that when the operator was setting up the conditions, she was able to type very fast, and it turns out that that's actually likely an unacceptable safety condition. So finally, 3 weeks later, patient being treated with electrons again, same operator, same malfunction. This time there was flashing lights and sizzling. Patient died from the overdose directly. In this case, it was very near the spine. Machine taken out of service, and the physicists and the operators really tried to reproduce the error, to make this error happen, and eventually managed to get it to happen if this prescription was entered very rapidly. So if you could type fast enough, you can make this happen. The frying sound was put down to the saturation of the ion chamber, so there was like shorting across the ion chamber, estimated dose of 250. The process then switched into a different mode, whereas previously, if there had been investigations, it was done by the individual centers and with or without the collaboration of the ACL. But then after this, it really switched into a different gear and became a more formal process involving the company, the FDA, Canadian regulatory authorities, a user group was set up, external consultants were brought in. That resulted in major changes to the software. So just to remember, June of '85, no action, overdose is possible. In Hamilton, we were advised to visually check the turntable position, and with some modification to procedures. Yakima, there's no action. We were told the safety had already was 100,000 times better. Tyler, no action. Tyler, it was reproduced. The action was disable the key. So we were all instructed to remove the key, physically remove the plastic key over that particular cursor control so that we couldn't enter the prescription so quickly. And then finally, after the second Yakima incident, FDA intervened in a major way. So I did my personal memories of this, and you know, as we know from Ishiguro, memory is a unreliable source of information. But my memory was I was sitting snoozing in my office happily one day, and a young radiation oncologist came in and asked me if I'd go down and see a patient, which was a little unusual. I went down, and the lady was lying on the table, and in looking at her, I could see a very geometric shape of severe reddening on one hip. My response to that was, that is a radiation overdose. I could think of no other possibility for it to be so geometrically shaped. And so I decided to take the machine out of service and initiated assessment by the people who are really expert in this technology. Taking the machine out of service was a non-minor task or action because of the fact that this was our workhorse. And therefore, we were horribly backed up and were running extra shifts on the other machines and were sending patients to other clinics, etc. So this was not a minor thing to do. I then informed Atomic Energy by phone as to what had happened and my opinion that this had been a radiation overdose. And I also decided to, this was before the days of internet, so I got on the phone and called up the 2 or 3 other centers which I knew had Linux, Therac, and indicated I thought we had a problem that may have resulted in overdose. I didn't have a recommendation as to what they should do. It was just that, red flagging that this had happened. So the technical analysis again was that we could not reproduce the error condition. And our conclusion was that the turntable interlock had failed. I'm not sure you had that down in a moment. So we removed the interlock and did the rather odd action, you may think, of placing it in an envelope, sealing it, and giving it to a lawyer. And the reason we did that was that the director of the center and myself thought this has been an overdose situation, there are going to be lawsuits. We think this is the cause. If this is a faulty device, we better have that secured. And so we did. We kept the machine out of service pending resolving this problem. The interlock is shown here. Basically, in the turntable, there's a 3-position or a 3-sensor interlock, which was supposed to tell you that if you set electrons, you were on electrons, and if you set X-rays, you were on X-rays. So we were very uncomfortable with the situation, and I have to say, somewhat against the advice of the ACL, implemented an in-house hardware fix so that the turntable could not be in the wrong position, even if the interlock failed. We were assuming, of course, because it couldn't think of anything else, that it was the interlock that had failed. So this was intended to solve that problem. And we put the machine back into service. When we got the subsequent disable the key notification, we then realized for the first time that the interlock might not have been the issue, and that may have been something to do with the computer. And so we initiated an external technical review. We got a chief physicist from one of the other cancer centers in Saskatchewan to come and spend a month, and he did a very detailed technical review before we recommissioned. Eventually, however, after the subsequent accidents and all the iterations of software changes and hardware changes, we took it out of service because we came to the conclusion that this was not that it could not be made safe because we really didn't understand properly what was happening. So, with hindsight, should we have done this differently? And for the Catholics in the audience, I just put up the mea culpa. It's easy to go back and say, I confess my sins here. So I think and I put myself in this, our biggest oversight as a community, I include medical physicists and engineers, was in assuming that the fault was hardware. Recall that at that time there had never been a Linux operated by software. All the faults that we've had in the history of radiotherapy have been hardware related. And therefore, to be honest, our tunnel vision was that there's hardware fault. Never occurred to us that there could be a software fault. In spite of the fact that I've done my PhD at CERN, where we ran common software of many, many thousands of lines of code, and as a graduate student, it used to delight us to see if we could make the software go to a condition where you get a message saying, we don't know what's happened here, we recommend you start again. So it's in the back of our mind, we knew that software, you could get into software conditions where you didn't understand what was happening. But in this case, it didn't occur to us. We thought this was a hardware fault. And if we'd been more open-minded, we might have initiated some of these tests earlier. Although not in self-defense, but perhaps in some mitigation, I'm not sure we would have found the real cause, which was related to this speed of entry of data, because it was a very peculiar thing to try to reproduce. Anyway, it opens up a more general discussion about safety, and there's these famous quotes from Donald Rumsfeld. You remember that we know there are known knowns, and there are known unknowns, and then there are unknown unknowns. And so when you think about it from an engineering perspective, was this event a known unknown, or an unknown known, or an unknown unknown? The comparison is this. When the Challenger disaster happened, obviously something had gone wrong. What on earth had gone wrong? And it was only when Feynman, as a completely, he knew nothing about rockets. He's a theoretical physicist. He knew nothing about rockets, but he's a very clever guy. It was only when Feynman asked the real questions that it was found that this was caused by a trivial problem, which was to do with the fact that an O-ring, the rubber of an O-ring, became inflexible and launched on a cold day. And the O-ring failed and allowed seepage of the rocket fuel, which then exploded. So that's definitely an unknown unknown, because you would never even think of that. If you go through, I'm sure that NASA had huge safety engineering processes, but for someone to ask what would happen if it's cold and the O-ring is rigid, nobody's going to calculate that. So if you go to the Levinson report and subsequently, she identifies, in a general sense, what can be the factors involved in software malfunction. First of all, obviously, overconfidence of software. You assume that software is right. Confusing reliability with safety. So, to some extent, AECL's reaction from this was the software can't be wrong. It's worked correctly in thousands of patients. It's highly reliable. It is highly reliable, but it wasn't safe. Because you could take conditions, rarely, that were unsafe conditions. It turned out when it was looked back at how the software was developed, it was kind of cobbled together. There had been software on previous generations of the machine, Therac 6 and Therac 20, and they had never had any problems. Parts of that software were lifted over into Therac 25 without really being retested or revalidated. And the reason that the Therac 6 and Therac 20 didn't have problems was that they had hardware overrides on the software. So even if it was a software fault, the hardware interlocks would prevent an accident. And it turns out that they were able to reproduce on the Therac 20 the same software problems as that has been on the Therac 25. So it's just by the grace of God that the Therac 20 didn't kill people too. Failure to eliminate root causes, complacency about it, unrealistic risk assessments. Where did the 100,000-fold improvement in safety come from? Some hypothetical assessment of risk. Inadequate investigation, that's certainly true. We were culpable in, we should have taken the machine out of service and tried to reproduce it and looked into both the hardware and the software. Inadequate software engineering practices as a term of software reuse, safe versus friendly, it's a big issue. The Therac 25 was pretty friendly, it was doing it very fast. The operator could really whiz through the patients on this machine, but it wasn't safe, as it turned out, because of that. Really, at that time, there was a lack of oversight and controls. In fact, it was the Therac 25 incident that led FDA and many other regulatory agencies to really start cracking down and putting requirements on software design and software validation, because it was recognized that this was going to be an increasing problem. So I think Margaret's going to tell us a little more about the actual software issues, and then I'll try and wrap up.
Okay, thank you, Brian. This is Marco Carlone back again. I'm just going to talk a little bit about some of the actual things that went wrong with the software, and then for those of us that are here in the course, we'll talk about it a little bit more tomorrow. So just a bit of a teaser. So the software control of the Therac 25 was done, as we've learned, it was computer controlled. So this diagram over here on the right kind of explains a little bit about how the computer control of the Therac 25 works. It's a very complicated diagram, and I have to confess I don't exactly understand it completely. But essentially, my understanding is that there's a certain data entry which forces the operator to enter a mode. Now, this mode could then be edited later. So then there was a keyboard handler that had a data entry complete flag. So there's a flag that says, "Yep, all the data is entered." And this is set what it does is it changes the state in a part of the software called the MEOS. So then the turntable is set by a different task, so a hand task as opposed to this MEOS task. And what happened was that the software controller didn't verify that the MEOS and the hand task were consistent. And now again, given that you can edit the mode after you've entered it the first time, then this obviously there's a lack of redundancy, a lack of checks, and it's all done through software. So there's no checks of consistency. So there are some principles about interlocks and medical Linux that have been developed since then. So some of the principles are that the interlocks are independent of the control system. So the control system's job is to set the state of the machine, and then independently the interlock system then says, yes, this is what we wanted, this is not what we wanted, and the two of them don't interface with each other. And the interlocks are controlled at a higher level than the control system. So the interlocks is kind of like the goalie, and its job, its control system. It has to be at a level where it can't be interfered with by any of the other control systems. So there's a hierarchy of controls, which is important in safety systems. And so what the interlocks do, their job is to detect an encroachment onto a dangerous state. So where the state of the machine is different from an intended state, or some sort of maybe either the state that the operator thinks that the machine's in, or that the designers thought that the machine could get into. So when the machine encroaches on a dangerous state, the interlock is supposed to detect that and then steer you to safety. And so the dangerous state can be either dangerous for the patient, as was the case with the Therac 25, or dangerous for the machine itself. So the Therac 25 had, I think we pretty much recognize now, a poor control system. The computer control system controlled the operating parameters of the Linux, but it did not independently verify them. So in this case, there was a large beam current, and that beam and the safety of the machine depended on the presence of a target to intercept that beam current before it went onto the patient. And so there's no independent checks of that. So the operator entered state requests into the console in an unexpected way, and then the result of that was that the actual state of the Linux differed from the control console's model of the Linux state. So in tomorrow's lecture on patient safety, we're going to get into the concept of the model or the state of the machine, and what the operator thinks the machine is, what the designer thinks the machine is, and what the machine actually is in. And those states are not always the same, and that's when you can have dangerous situations. So I'll just pass it back now to Brian to finish off with some final thoughts on that accent.
Yeah. So just to sort of prompt some discussion, when I was preparing these slides, I looked up Wikipedia, which of course is a source of all wisdom, to see what it had to say about software system safety. But it's actually quite useful. It's optimizing safety, design, development, use, and maintenance of systems, and how they're integrated with safety-critical hardware systems in a real operating environment. So it's actually quite a thoughtful definition of what you should be considering in terms of software safety, not just for Linux, but for any type of software-controlled device. And I've lost it. Hardware controller. I've lost the controller. Okay. And there are now, as you may know, standards that are developed for software that are applied throughout many different industries. And there was a document generated in 2002 by the US FDA to try to, at least at that time, capture this, and it applied to software used as a component of a medical device, software that is a medical device, such as is used in physiological monitoring, software that's used in the device being produced. So it could be software that never gets into the device that actually gets to the patient, but was involved in the design or the construction of the device that's used in the patient. And then software used in quality control, because if you're doing QA, and that's a software-driven instrument, then your QA will only be as good as the validity of the software in that instrument. So it's at multiple levels, some of which, at least to my mind, were not very obvious, or were not well laid out at that time. And you just see in the quote at the bottom there that it was found that a significant percentage, 7 or 8%, of failures of medical devices were attributed to software. So it turned out to be a very non-trivial issue, that there are a large number of medical devices, and increasingly they're software dependent. And so validating the software is very critical. And then just point out now that software safety and QC is in fact its own discipline. And one example of that is close to here at McMaster University. There's a whole group, and I just sort of put the postage stamps pictures of this. Was a couple of years ago. This is a team of 10 or a dozen people at McMaster who are in this thing called the Software Quality Research Lab, and all they do is think about the issue of how you ensure quality in software. And so we had some interactions with these people, just as an example, with a device that I was developing a few years ago, and we were quite far down the development of this device, which was a camera device for use during neurosurgery, for brain tumor surgery, and this was all nicely software controlled, etc. And we were thinking we would maybe commercialize this. So we went to the guys at Swirl and said, what do you think of the software that we've got? And they said, it's appalling. You just cobbled this together like a piece of lab software. You have, what was your quality control in the design of that software? We said, well, the student wrote it. And that sort of thing. And so we worked with them quite a lot to see could we rescue what we had done, or would we actually have to throw the whole thing out and start from the beginning with proper software design, proper software control, validation processes, etc., which turns out to be very complex, in fact. So it was an interesting lesson for us. Anyway, I hope that's given food for thought, and we can have some discussion about it. You want me to stand here?
Yes, stand here, and we will,
and I guess we will have questions from the people on the webinar as well, right?
Yes. So you'll let any questions come in. Okay. So thank you, Brian, for that. Was always very interesting talk, and a very to me. I mean, I think we're talking today a little bit about some of the failures of these machines. These machines can inflict a lot of harm on patients, and I think fear is a good, healthy thing when it comes to these machines. And fear can make sure that we do the right thing. And so I think in these cases, it's always good to be respectful that these machines can be quite damaging. So we've had a lot of good discussion all week. So I'm sure there must be some questions for Dr. Wilson from the floor.
Or derogatory comments.
Yeah.
I was just wondering if you the data you showed about the software incidents from 92 to 98 was interesting. Given it's about 10 or 15 years old, is there, and given that software is taking a much greater role in medical products these days, is there more recent data? Is it
I'm not sure. I mean, I made these slides up for this talk for the first time last year, and that was what I could find, at least on the web, not with a very deep search, but a year ago. So I don't think it's that out of date. But maybe, I'm not sure, maybe someone else can comment on that. But it's obviously, I mean, the whole issue of software-dependent medical devices is now a pretty big issue. You know,
I can only imagine the
it's starting to be hard to find a medical device that's not software dependent, whether or not it's software controlled.
You indicated that the first Aston McMaster was 85.
Right.
You took it out of service in 86, right?
87 finally.
87.
It's right.
Okay.
And it was in and out of service during that time.
Could you just estimate how many more patients did you service with that machine over that time frame, that 85 to 87 time frame?
Well, we were probably running 20 patients a day. So that's say 5,000 treatments, 10,000 treatments, I would say. Yeah.
So in this case, with that software, that one operator just happened to do it fairly quick at that time frame.
Right.
That one chance, and after that, no other operator. It never happened again. Nothing.
Well, we implemented. It may have been the case that the operator could that happened again with the operator, but we implemented the hardware override. Now, in retrospect, we don't know whether the hardware override that we implemented blocked that operator error, right? Because we were working on the assumption that it was interlock related,
right?
And therefore we implemented a hardware fix to that. But that wasn't a direct hardware fix of the software-dependent fault. Right. So we probably, you know, I don't know the answer, but my guess would be that we didn't fix it.
You didn't fix it.
We didn't fix it. Really. When the later instruction came from ACL to disable the cursor, that probably fixed that problem, because at least it prevented this very rapid entry of the treatment. But subsequently, there were other. It's not clear that the later accidents were caused by the same problem.
Okay.
So the suspicion was appearing that there was more than one software fault that was leading to these accidents.
Okay, so the hardware, more or less, you believe is all more or less fairly well done. And after you fixed the turntable, even with that fix, you thought the hardware was always good. It was always the software problems with all the investigations came down to.
Essentially, I mean, essentially this was the software, where at least one, probably more than one software problem.
It was never like you do have three areas of possible error. You have hardware, software, and then you have human error.
Right.
And so it was never brought into the human factor brought into the case.
It was caused by human capability, if you like. Well, right. I mean, the irony was, if I would personally never have killed a patient because I'm a terrible typist. But all three were involved in that sense. There was the absence of a hardware override, as Margaret said. So that was a glaring, with hindsight, deficiency. There were actual software errors to do with this race condition. That the software was faulty. And then the faults in the software were only manifest under certain operating conditions.
If I can just add to that. So I'm not an expert in safety systems, although I've been thinking about them for a long time, and I've been to a number of conferences, and I've organized conferences around safety and quality. And my understanding is, from listening to people who do study this, is that the current thinking is that the term human error is just not appropriate anymore. So I mean, humans will always make mistakes. Whether it's impossible to prevent human beings from doing things correctly all the time. We're not machines. We're not robots. We can't do that. The system has to be designed in a defensive way such that those mistakes will be channeled in a way and caught and so that the state of the machine never approaches these constraints where you can have a dangerous situation. And so and there's a number of examples about this in the literature, and the people study this, and notably tomorrow we'll discuss a book by Nancy Livingston, that Dr. Wilson mentioned today, where she's kind of analyzed this very systematically. And there's a process by which you can design machines now, which is recognized, where really human error should not be even discussed anymore, because it's just not something that you can point to and say, that person shouldn't have done that. I mean, unless it's willful intent, that's different from just I did something that I didn't intend to do, because you can always do something that we will make mistakes. I make mistakes all the time, and but those mistakes shouldn't kill somebody. I mean, that's just not that's not my fault. That's bad design, I think. So
there's an interesting post-it there, the bottom one.
Yeah. Yes.
Behind human error. Has anyone come across that?
My concern is that, is there any way to really avoid this kind of problems? If you don't have a detector to verify if the patient was really radiated or not, then you depend on the keyboard software. Right. If the software tells you that the patient was not exposed to any radiation, but actually the patient was, then what do you do?
Right.
So is there this kind of technology, like when the patient
yeah, I mean, as Margaret says, the correct way to have done this would be to have the verification that the machine conditions were as intended should be independent of the operator-driven software. Right. So, but now, you know, at that time, the thinking was, well, you do that in real engineering hardware. Mm-hmm. I'm not so sure now. I mean, maybe it raises the question: would it be acceptable to have the independent system also under software control?
Yes, because
in a different set of software. Is that acceptable? Or are we saying that we won't allow any machine near us that is where our ultimate safety is dependent on computer programming?
I thought I still have these kind of things, but in the opposite direction. You hear it's the patient was exposed, but it says not.
Right.
But I saw the other thing happens is the machine tell you that the patient is exposed, but it's actually not.
Right.
So, but they're the similar problem.
Right.
So
Right.
really, I'm thinking, is there any way or any idea?
So I mean, yeah. So I think there are methods. I mean, we'll discuss these tomorrow. We have a lecture tomorrow on patient safety, and I'll discuss some of the approaches that people have used and have outlined in ensuring safety in medical devices. I think the problem today is that I think there is, as Dr. Wilson said, there's now a group. This is an entire field of study by itself now. So people study this. The problem, I think, is making sure that these methods are now implemented across the board in a consistent way. And this is what FDA, Health Canada, this is what these agencies, their jobs are. And I think even though that we all recognize this is important, there are still challenges to make sure that these principles of safe design are not compromised when the device gets to human use.
So think about it. I mean, in normal daily life, we drive along the road in cars that are really run by software, and there's been not a few recalls by car manufacturers for software errors in cars. Now, I don't know whether they translate into your car going off the road, but even in presumably massively engineered consumer devices, this remains a problem.
So I just have to interject. So unfortunately, we're coming up to the end of our session. So it's 5:20. So this has always been a very popular lecture. We've had it 2 years in a row now. I think it's generated a very good discussion both times. So I'd like to thank Dr. Wilson for a very interesting presentation.
Okay, thank you.
And hopefully you'll come back again next year.
Thank you.